Dr. Rchet is a doctor. He trained at the University of Saint-Étienne in France and worked as a clinician for a couple of years before going into a formal academic training in epidemiology, where he completed his master's in Paris and his Ph.D. in epidemiology from EARC, the International Agency for Research on Cancer. His current research is centered on cancer survival, and he's the co-principal investigator in 2 successive 5-year Cancer Research UK program grants. He's carrying out a wide range of projects to quantify, describe, and explain patterns and trends in cancer survival by socioeconomic group, geographic area, and ethnicity, as well as extending the methodology and tools for survival analysis in collaboration with many researchers and partners in the UK and around the world. He developed a startup program for relative survival analysis, and we're actually very excited to have him here, being us as a group very interested in this area of using cancer registry data and these kinds of databases to answer research questions and generate research hypotheses. So thank you for being with us today.
Well, thank you for inviting me. It's the first time I've been in Puerto Rico, and I've already have a good, quite interesting experience today with the elevator. I was stuck in the elevator during the lunchtime, but the hotel staff was quite efficient. And, what I'm going to talk about is echoes quite a lot of some of the presentation from this morning. I will try to show what the impact of global results can have at local level, and I will focus on cancer survival. But the global surveillance of cancer is not new. There was some attempts, first in mortality and in incidence for 60 years, 50 years, although at the beginning it was just an attempt, it was not worldwide. But progressively, most of these studies, the WHO Cancer Mortality Database and the CI5, the Cancer Incidence in 5 continents, cover most of the world. And more recently, we have used survival. And I will go through a few examples of worldwide or at least international or quite wide studies, and EUROCARE and CONCORD. The SEER program in the US is also quite wide, but I will talk mostly on EUROCARE and CONCORD. And the main reason of these, or the main characteristic of these studies, is that they try to have to use identical standards, to use a unique protocol, and to centralize the data management and the analysis. And the objective of this is to have a comparability of the results. And I think the impact of these studies, of the results, are on 2 main levels. First, on the health policy level, and second, on the data, on the quality of the data. And I will show this in a minute. The EUROCARE studies is probably the first multi or multi-centric or multi-country studies in Europe on cancer survival. Actually, it was a much larger program than cancer survival. There's also in childhood care, in childhood cancer survival, etc. Now the EUROCARE 5 is going to be published. The results from EUROCARE 5 is going to be published. But the first EUROCARE 1 was published in the 90s using data from 1978. And it was 30 cancer registries in 11 countries. And now most of the European countries are covered. It's about 35% of the participating country population, of course, because in many countries the cancer registries are not national; they are just regional. Okay, but still, it covers quite a lot of different countries. And you can see for EUROCARE 4 here, I hope you recognize Europe. Then you can see that the Nordic countries here, they have national coverage of the cancer registries. For the UK also, but also we have the Latin countries and Central Europe countries with a lot of regional cancer registries, and more the middle-income countries from the Eastern Europe are included in the EUROCARE studies. What are the main lessons from these studies? The first is we have observed from the beginning wide disparities in cancer survival. And it's really wide. It's not much wider, for example, than what we observe in the US. And there's also very great variability between the patterns of cancer survival. And when I said pattern, it means the time trends and the pattern of survival from diagnosis, for example, short-term survival versus conditional survival, but also by age. For example, the elderly have very poor survival in some countries, and particularly in the UK, much poorer than in other European comparable countries. The high-resolution studies, and I will talk about these type of studies, showed also that the cancer management varies quite a lot between countries in terms of the type of diagnostic investigations and also in terms of treatment, and particularly the adherence to international guidelines. And following these results, it provoked a lot of debates nationally and locally, and in most of European countries implemented national and regional initiatives, and even in countries like Sweden or France, where the survival is quite high compared to other European countries. In the UK, when the first EUROCARE studies were published, it was a shock for the UK because the cancer survival was poor, and really poor compared to most of the Western European countries. Poorer than in Italy, in Spain, and there was a lot of dispute in the country, and after a few years, everyone started to recognize that the results were true. It was not just an artifact of data or because the UK had a national coverage, etc. And you can see here, this is from the Guardian, saying that Britain is lagging behind in cancer care, culture that kills, and the tabloids also published quite a lot of papers. And then finally, in early 2000, the health minister responded to these results and recognized that we needed a really comprehensive cancer plan to speed up access to high-quality services across the country. And then what we call the NHS cancer plan was implemented in 2000 in England, and it was a comprehensive 10-year strategy. It was not just a small initiative, and with a few aims to improve the prevention, early diagnosis and screening, to provide optimal treatment for all patients. And there was another concern, it's the very wide socioeconomic inequalities in cancer survival, particularly in England, and also to improve survival and the quality of life. And as a result, there was a 35% rise in the annual funding for the 3 years in the 2000. There were also cancer-specific guidelines which were written. Also, the multidisciplinary teams of specialists for each cancer type, for breast cancer first, and then lung cancer, colorectal cancer, etc., were implemented to manage, monitor the cancer patient. It was followed by the Cancer Reform Strategy in 2000, the NADI, National Awareness and Early Diagnosis Initiative, and I will talk about that later. And the cancer plan was confirmed and updated in 2011. Actually, in most of European countries, now in 2013, most of the European countries have integrated national cancer plan operating or in preparation. And it was to address the very wide inequalities we still observed in Europe in both cancer control and in the cancer survival, and both between all these European countries, but also within most of these countries. And you can see in EPAC, which has some publication on that, and to see all the different, the description of the National Cancer Plan. More locally, there's also some impact, and strong impact. This is from Italy, and the first, you can see, I don't read Italian, okay, but it's quite close to French, then I can understand, and to Spanish. Then it just says it's for Sicily. Then Sicily, it's the south of Italy. It's poor compared to north of Italy, and then the survival is really poor. And one of the newspapers said that when you have a cancer, you have only one thing to do, it's to pray for San Gennaro. And EUROCARE too showed that the survival was really poor in Sicilia, and the main problem was there was very few early diagnoses and also a lack of radiotherapy units in the region. And then there was a regional health plan for oncology, which was in actually 2003-2004, and which decided to implement the radiotherapy units in Sicily. Then the EUROCARE studies have a lot of impact locally, and one of the big positive results from the EUROCARE studies, I would say, is this capacity building. First, the population-based cancer registry data. There's now a lot of many population-based cancer registry data which are suitable in terms of quality for survival analysis. And there's also a critical research mass in Europe to manage this data, to analyze this data, and to interpret this data. And this is something we have seen in the last 20 years with the EUROCARE study. Then we can say EUROCARE was really successful for that. One of the main aims of EUROCARE was also a long-term objective, was to do some more detailed analysis, and in particular stage-specific survival analysis. And for that, it was a failure, because although the number of cancer registries has improved, has increased in the EUROCARE studies, the quality of the data hasn't really improved at European level, and we still have trouble to obtain more reliable and detailed clinical data at the European level. Now, more globally, the first CONCORD study, which was published in 2008, which was a study for worldwide, with, well, we can see 100 population-based cancer registry in 31 countries, with 4 cancers: breast, colon, rectum and prostate. And you can see the distribution actually is very uneven. It's mostly based on Europe and North America. And it's quite understandable because the initial objective of CONCORD was to compare the survival between and to understand the differences in survival between US and Europe. But then many countries started to be interested, to express interest in this study and decided to join CONCORD, and the objective changed slightly, and we tried to do a 5-continent study, but without a lot of funds. Then it was quite difficult, but you can see that from Latin America there was only Cuba and 2 Brazilian cancer registries included. From Africa only Sétif in Algeria, the wilaya of Sétif, and from Asia only a few Japanese cancer registries. Nevertheless, there was still interesting results. There was a huge variability in 5-year survival for breast cancer, and with the here you can see the Eastern European countries, Brazil and Algeria, with a very, very poor prognosis. And I will focus first on Algeria. Algeria, well, not surprising, has a very poor survival for breast cancer, but also for the other cancers. And there was at the beginning quite a lot of debate on that. The politicians started to be very unhappy. Some epidemiologists also discussed this. And there were legitimate concerns. Sétif is a small wilaya compared to the whole country. Algeria is quite wide, quite big. And they argue that most of the cancer patients to get proper treatment will go to the capital of Algeria. Nevertheless, there was a general argument among the epidemiologists in Algeria that the results reflect really a poor survival and poor access to healthcare, and both at diagnosis and treatment levels, and it just reflects the low health expenses in the country. There was a strong and still now a strong political embarrassment, not only in Algeria, but all North Africa, because of the absence of the other countries and the poor survival. There was an audit on cancer registration, cancer incidence, and cancer survival in the Maghreb and Rchet countries a few years ago, and to try to understand why they had so bad survival. And as a result, there's a political, a higher political involvement in cancer registration, and at least 4 of the 8 Algerian cancer registry will participate in CONCORD-2, which was launched a few months ago. Tunisia, Libya, we don't know at the moment, but Libya was interested to be involved, but the political situation is not clear at the moment, and Jordan, and will be included in CONCORD-2. And there's also some negotiation between cancer registries from North Africa and the French National Cancer Institute to support the assessment of vital status, which is a big problem in these countries, of the cancer patients registered in these countries. But CONCORD has not only some impact on countries with poor survival. This is here for US, with a very high survival, one of the highest in the world. And this is for breast cancer again. So far, the survival results were represented by the SEER program. And the SEER program covered more or less at that time 9% of the national population, then 14%. most of the the SEER cancer registries were based in relatively affluent areas. And then for the first time, the study included also the NPCR cancer registries then, from the CDC. And you can see if you compare then the first the SEER, which are round, and the triangle NPCR, but the survival from SEER usually is higher than the survival in the NPCR area. Another point is that if you compare black and white, the disparities in 5-year survival is huge. And the differences in survival is much wider than, for example, what we observed in the UK by socioeconomic status. It's really, really something important. Another point which is more methodologic, for the first time, we have to use life tables to correct for the background mortality because it's relative survival. And for the first time, we use life tables specific by state and by race, which was not the case in the SEER program at that time. Then the low resolution studies showed usually that there was a higher survival in the US than in Europe. And one of the explanations was the stage at diagnosis is earlier in the US than in the Europe. Then some high-resolution studies were performed, like in the Europe, to investigate the origin of these differences. And high-resolution studies are just random samples of cancers where we collect in the hospital from the clinical files detailed information on stage, on the diagnostic procedures, on treatment, and of course on we set the follow-up. And I will focus on this one, breast cancer survival, where we were interested to compare the stage distribution, the stage-specific survival, and then to see how the countries adhere to guidelines or standard care for breast cancer according to age, stage, and the hormone receptor status. 7 US states and 12 European countries were involved. Then for each cancer registry, at least 500 cases were collected and with more clinical information. And the first results is you can see that the proportion of early stage is much higher in the US than in Europe, and the proportion of late stage is lower in the US than in Europe. But also that the disparities in the stage distribution in Europe is quite important, and Eastern Europe is really had very adverse stage distribution. And these disparities in Europe is less important usually than in the US within the different states of US. Again, a result which was a little surprising, compared to the early 90s, survival in Europe was not so different from what we observe in the US. And actually, if we look at the northern, western, and southern Europe, it's very similar to what we observe in the US, while the problem is really in the Eastern Europe. And we can see again, as I said, was a lot of variability in Europe, and than in the US, and most of the problem is in can see here the Eastern Europe. It's Eastern Europe, and particularly for the advanced disease where the prognosis is really, really poor. Also, we looked at the pattern by age. There's a small mistake here. It's not Central Europe, but Western Europe. Okay. Then you can see that the Eastern Europe has quite a poor excess mortality, then cancer-related mortality up to 5 years. But if you look at the elderly, it's even worse. It's really a very high cancer-related mortality up to 5 years, but mostly in the first 12 months, as they don't really treat the elderly. Again, if we look at the early diagnosis versus metastatic, we have also this same very high cancer-related mortality in the Eastern Europe. Something also we look at, it's the breast for the early stage tumors, breast cancer again, for breast cancer conserving surgery associated with radiotherapy, which was already in the most guidelines at that time. And you can see for Eastern Europe, again, it's a very low proportion of this type of treatment. And if you look at relation between the BCS plus radiotherapy and the total expenses for health, you can see that in the Eastern Europe, these expenses are very, very small, very low. Then in conclusion, from that, the differences in breast cancer survival between Europe and the US in the late 90s were mainly explained by lower survival in Eastern Europe. And the low healthcare expenditure may have explained some of these differences and then have constrained the quality of treatment in these countries. What is very important also is we need this population-based data on stage and on treatment, and both the clinicians, the oncologists, and the epidemiologists need this data. And so far, the high-resolution studies were the only valid way or design to collect this information and to address this type of research question. Of course, and I will come back on that later in my final conclusion, we need some funding for the cancer registries. I don't work in the cancer registry. There was maybe an alternative. It's the International Cancer Benchmarking Partnership study, ICBP. This study was actually a big program initiated and funded by the UK Department of Health with 5 modules. Module 1 is on cancer survival, and we lead the analysis. Module 2, for example, is about cancer awareness, and they looked at cancer awareness in different countries. Here there's then 8 countries, if we count England, Northern Ireland, and Wales as different countries. It seems it's the geography is, with the UK is very variable, depending if you are in the Olympic Games, football, or what. They modify this, but well. There's a quiz if you want to recognize the different flags. I can recognize these 2 after it's all crossed, so then it's very difficult to know which one is, but it doesn't matter. Then the population base was 123 million, and we looked at 4 cancers: colorectal, lung, breast, and ovary. And the phase 1 was just to look at survival by age and by jurisdiction and countries. And the conclusion was that Denmark and the UK had a very low survival compared to the other countries. Norway was in the middle, but the other Sweden, the Nordic countries, and Australia and Canada had quite high survival. And there was then the phase 2 stage-specific survival analysis, and phase 3, the analysis of treatment. That was the objectives. When we started to do the phase 2, then to look at the stage, we faced a big challenge. There was a huge there were a lot of effort from clinicians from the different countries, epidemiologists, people working in the different cancer registries to standardize the stage data and the treatment data. But actually, it appears that in the different cancer registries, they all use different stage system. And it was SEER 2000, SEER modified in Australia, Norway had another system, TNM, etc. TNM group, TNM detail, and we had to work a lot, very hard to try to combine these data. And we published this in the International Journal of Cancer. And we had also to select the cancer registries and the period, because the completeness of the stage data was quite low in many cancer registries. We nevertheless succeeded in publishing the papers on the different countries. And there was two main results about these inequalities or international differences in cancer survival. Then the first, adverse distribution of tumor stage and low stage specific survival. And actually the results were quite unexpected. And I show you this for the UK. First, ovarian cancer survival poor in the UK. We knew that, it's not a surprise. But then, actually, the main concern and the main objective of most of the initiative in the UK was to try to have early diagnosis, to speed up the diagnosis and the treatment. One of the assumptions was that the woman or the patient tend to consult lately. And actually, what we showed, it's the women were wrongly blamed for going to doctor late, because actually the distribution of stage was a little worse than in the other countries, but not so bad. While in Denmark, it seems it's the main problem. The main problem in the UK seems to be the standard of care. And standard of care, it can be the diagnosis investigation, and if the diagnosis is not complete, then it can lead to wrong treatment, and also the treatment. And we knew that already, that the rate of radiotherapy, of curative surgical procedure, etc., is usually lower in the UK. Then, as a conclusion for this, how long? It's okay. Well, it's first. Every time we publish this type of study, there's a lot of media coverage, a lot of debate also among the politicians. The other thing is, because of this problem of tumor stage, it led to debate within the cancer registries, but also in the UICC, to understand and to improve the international staging system, TNM. And there's a sort of conflict of interest between the oncologist and the epidemiologist. The oncologist would like to have a very detailed stage system, because they think individual patients, while we think population. And then we at population level, we don't need very detailed staging system. We need something a little more wide and usable and feasible in routine data. The data quality, again, there was a major overall effort to make the data comparable, and the tumor stage and treatment to improve the quality and the completeness. And in different countries, it led to work on that. For example, in Quebec, one of the provinces in Canada, they were not included in the ICBP. They were not included in the first CONCORD study. They are not included in most of the national cancer survival studies in Canada because of concern on the data quality for decades. Then the politicians started to be a little nervous about that, and they decided to make effort on that to review their registration system. And we conducted an independent audit in January, and it seems they have improved quite a lot their data. In England also, the cancer registries, first try to explain the low survival, low treatment proportion by a problem of data, and then they reviewed their data and acknowledged that for several of the regional cancer registries, the data were inadequate for international comparison. Then, as I said, the Department of Health realized maybe they had to review their priorities, and currently there have been quite a lot of debates. We were involved in these debates. If we had to focus more on the high-quality cancer management rather than on patients. And the NADI, what I presented, the National Awareness and Early Diagnosis Initiative, was really to focus on the early diagnosis and awareness, etc. And it seems that, it's probably important, but they have to make some effort on diagnosis and treatment. And I will finish on CONCORD-2, which was launched 3 or 4 months ago. Then it was clear just after the publication of CONCORD-1 that we needed worldwide surveillance of cancer survival patterns and trends. And cancer survival has been included in as a main outcome in the UN Summit on the non-communicable diseases. So far, we have about 250 population-based cancer registries in 65 countries. Quite importantly, a few more cancer sites, and some have been really from the demand of the low and middle income countries, and particularly, for example, liver, cervix, and the childhood acute lymphocytic leukemia. This cancer has a very good prognosis if it is treated, and it reflects really directly the efficiency of the healthcare system. This is to show you that the distribution is much better, more even than in the past. The Latin America is much more represented. Asia also, with China, India, and some other countries, and even in Africa, even if it's still sparse, we have 7 countries. This is here just to show you the number of additional registries and countries, then 7 in Africa, 13 additional countries in Asia, and in Central and South America, 7. And let's see in the region. To my knowledge, there's only 6 population-based cancer registries. Maybe there are more, but I'm not aware of. And in the first CONCORD, there was only Cuba, which was included in it. You can see that some of the cancer registries are not included or have been taken out of the CI5, the cancer incidence in 5 continents from IARC. And for CONCORD-2, Cuba and Puerto Rico decided to participate. If there are other candidates, please you. Another point, it's Mexico with Greece are the only OECD countries without population-based cancer registry. And that's quite important to notice. Now, almost all other OECD countries have regional or national population-based cancer registries, but these 2 countries have only hospital-based cancer registries, not population-based cancer registries. Then I will finish on that. I think the question important to ask to the cancer policy makers are this type of question. The first is our population receiving optimal care? And are they up to the international standards or the international guidelines? Are there some disadvantaged groups, for example, by age? We know that in some countries, as I've shown, the elderly are not very well treated. And the other thing is also to ask if the services are adequately monitored. And this is necessary to evaluate the performance against the objectives and to identify the hospital or doctor underperforming. And all of this can be done with population-based cancer registry data. And in conclusion, then, well, we've seen there's a high visibility of the results of these studies. And it's very frequent that these results, because of this high visibility, will increase the awareness on the inequalities in cancer survival. And when I say inequalities, the international disparities. And it increases the awareness in the general population first, among also the GPs and the oncologists, which is not always obvious, and among the politicians. Well, we need data from population cancer registry to address the research question I've mentioned, with high quality data in terms of vital status ascertainment. The financial investment is also important, but it needs to be adequate. But you have to remember that it's a very low amount of money in comparison to some funding for biological studies or clinical trials. And it's very low in comparison to the benefits in terms of public health. But you know, you need strong and long-term continuous political support for cancer registration. Another point which we've seen in Europe, it's the local capacity. It speeds up the building of the local capacity for cancer survival surveillance. It improves the size of the teams in research for cancer survival, for data management, for cancer survival analysis, usually increases quite a lot. And finally, the monitoring progress in cancer survival, in cancer control. Well, it's important to implement some cancer plan, but if you have nothing to to assess the progress, to define, to evaluate the strategy and the plan, it's not very useful. Okay? Then the survival should be also included in this cancer control plan. Well, thank you.